Thank you for having me speak on complications with left atrial appendage closure. We have updated the title of this talk to be in line with the theme of this session on structural complication. The incidence of procedural complications with LAA closure have decreased dramatically over the past decade due to increasing operator experience and due to meticulous techniques as well for both the Watchman device as well as the Embolization devices. Now, the major procedural complications incidence is somewhere in the range of 1 to 1.5%, consisting of ischemic stroke in less than 0.2% of cases, tamponade in about 1%, and device embolization of 0.2%. Mortality related to the procedure is very rare at less than 0.1%. In terms of ischemic stroke, air embolism really is no longer an issue with careful techniques of aspiration and flushing the sheaths, avoiding dampening of the pressures, so this is really rare. Thromboembolism is more likely the cause for ischemic stroke, and it can be due to unrecognized pre-existing LAA thrombi or from thrombus that developed on the equipment during the procedure. Therefore, it's important to keep the ACT over 250 seconds or even have those happen before transeptal puncture. Pericardial tamponade has decreased in incidence from up to about 5% in early experience down to about 1% in most operators' hands. In the commercial post-approval experience in the US of 3,800 cases, 1% pericardial tamponade incident, 2/3 were treated with pericardicentesis, 1/3 required surgical treatment. With the amulet device in the prospective amulet registry, incidence of tamponade was 1.2%, 3/4 were treated percutaneously, and 1/4 required surgical management. The causes of pericardial effusion can be quite broad, maybe related to the transeptal puncture, or maybe related to manipulation of the sheaths against the wall of the appendage, or from the device hooks itself. In about 1/3 of cases, the cause cannot be identified. Most cases, about 90%, occur within 24 hours. Interestingly, patients in sinus rhythm have a higher risk of pericardial effusion compared to patients in persistent or permanent AFib. Now, prevention of pericardial effusion includes using proper imaging such as TEE or ICE to guide transeptal puncture, using pigtail to access the large sheath, minimizing device maneuvering in the LAA, and minimizing device recaptures. If you have cardiac perforation, this is quite rare, but it will require immediate mobilization of your surgical team, immediate pericardiocentesis. Because a large volume of blood is drawn from the pericardial space, you may need to return that to the central venous system or even use a cell saver. Importantly, if you have the sheath still in position and if that's extruded into the pericardium, do not withdraw the sheath until you have surgical access. If you're really experienced, there has been case report of operators using ASD PFO occluder to straddle the pericardium that has been perforated, but this is no guarantee for success. There's also device erosion that can occur. This is very rare. This is only 8 cases reported, published in the literature. 5 out of 8 cases had early tamponade within 24 hours. Most patients require surgical intervention. 3 out of 8 of these patients died. So this is an important potential rare complication. If you have a tamponade, you need to rule that out. In terms of device embolization, this is fortunately quite infrequent nowadays. With a Watchman Generation 2.5 device, the embolization rate was 0.25%. 2/3 were surgically retrieved, especially for the large devices, for these 27 or larger devices. For the amulet device, the incidence is about 0.2% in the amulet observational registry. Both these cases were removed percutaneously. In terms of timing of embolization, in this series they looked at 31 device embolization. Most, about 70%, occur acutely during the procedure or within 24 hours. About 30% of cases occurred late, found on routine imaging several months later. Most cases were asymptomatic, only 2 were symptomatic, 1 had palpitations, and 1 patient had cardiogenic shock. In terms of where device can embolize to, about 40% of cases they were found in the aorta, 40% found in the LV, and about 15% landed in the left atrium. How we manage depends on the location and also the hemodynamic status of the patient. Patients who are hemodynamically unstable usually is due to the device obstructing the outflow tract, such as the LVOT or the mitral inflow, and you need to use a catheter to dislodge, using a pigtail to dislodge the catheter of the device, or changing patient's position, which may not necessarily help, or immediate surgery. If the patient is stable, And the device is in the left atrium. You need a transeptal puncture to access and snare the device back. If the device is in the aorta, descending aorta, this is quite easy to snare. If the device is stuck in the LV, you're kind of it's a challenging position because of the mitral apparatus in place and the aortic valve in place. You might disrupt these structures, so sometimes you might require surgical intervention, or you use very careful percutaneous retrieval technique under TEE. We've published a couple of cases of retrieving M-Platzer cardiac plug devices. One was lodged in the LV, one in LA. We use the snare technique. These are the tools required for percutaneous retrieval that you need to stock on your cath lab. You need a large sheath ranging from 14 to 18 French. I find gooseneck snare more useful than end snare. Some operators have used vascular retrieval forceps. For instance, in this particular case, a 33 millimeter Watchman device was pulled back with two biopsy forceps, one grabbing the center hub of the device and one keeping the device still. And they pulled this through a 12 French sheath. And this is an example of a wave crest device that was embolized in the abdominal aorta where they pulled back using a trapping balloon technique. In terms of post-procedural complication, residual leak, and device-related thrombus, the peri-device leak is quite common with the Watchman 2.5 device. In overall incidence was about 32% up to 12 months. With the M-Platzer cardiac plug and amulet device, perhaps about 12% lower incidence than Watchman. With the new Watchman Flex device, the incidence of any leak is a lot lower compared to Gen 2.5, but 10.5% versus 32% at 12 months. So very promising new device. Now for large leaks less than over 5 millimeters, some operators have implanted a second LAA occluder. Some have used vascular plugs to close the residual hole. And there have even been reports of using Vascular Coil. This is experience from Andrea Natale's and Rodney Horton's group, where they use in 30 patients these coils to close leaks greater than 3 millimeters. In terms of device-related thrombus, these can occur in 2 to 4% of these endovascular devices, and maybe due to deep implants or exposed screw, etc. DRT can result in stroke in about 10 to 15% of cases, so they need to be managed with either warfarin or NOAC, or enlarged thrombus with low molecular weight heparin or surgical excision. So in summary, major peri-procedural complication is infrequent nowadays with LAA closure in about 1% of cases. We need to survey for complications such as tamponade with transthoracic echo at 24 hours, and also device imaging at 1 to 3 months, and even repeat imaging at 12 months to rule out DRT and peri-device leak. You need to have the proper equipment to manage tamponade and to retrieve embolized devices percutaneously, and also when to need surgical help. Thank you for your attention.